they had a sound sleep. And just to recapitulate what we had, and Dr. Aditi had presented on minimal change disease and FSGS in pediatrics, and she said that 4 to 6 weeks is the therapy, and if after 6 weeks there is no response, we need to call it as resistance and frequently relapsing. These are the definitions which he has presented, and we have to use all these investigations to come to a conclusion to rule out the secondary causes. And we know that even a minimal FSGS, if there is a partial response, it also has a good outcome as compared to resistance. And if he has a response, it's a good outcome. So we need to try to reduce the proteinuria so as to achieve a partial remission. So these are the resistant therapy guidelines in 2020, and we have ACE inhibitor ARB supportive care, and then we'll have non-response. We'll have to use calcineurins and then rituximab. We'll have to rule out genetic causes. And this was Dr. Anila presented on Lupus Nephropathy. Looking at the picture also, she said we can recognize some of the etiologies like so Neil also and smudgy appearance of everything. So we can have multiple genes have been, but again everything we can't have a concluding antigens which are not available in India. Almost around 95% she said we are able to identify, but now we have only available 6 or 7 antigens, so we have to only around 80% will be able to cover, and in the next. So depending on the etiology, we'll have to investigate. Like if there's a TLR2 or Neil1, we'll have to know autoimmune, malignancy, more so in the allopathy or a Siddha medicines, and we need to. So Dr. Raja Ramchandran summarized Lupus Nephropathy treatment as standard of care is Ponticelli, and rituximab may be as good as in and as Ponticelli regimen, and then other therapies which are emerging. We can have a combination of rituximab and cyclosporine. So this was the support conservative therapy and plateau are monitoring. You need not have to wait if the plateau are very high, where the response may not happen within the 6 months, and then we need to treat. We need to rule out a malignancy, and we'll have to take care of the fertility issues when we are treating with cyclophosphamide in the young. So anticoagulation has to be there when the albumin is less than 2.8 to prevent thromboembolism, and rituximab and even a corticosteroid withdrawal will be necessary. Then Dr. Balan presented anti-GBM disease, and he said the recommendations are less, so because the no randomized trial is large, so but still it's a corticosteroid, cyclophosphamide, and rituximab. Maybe plasmapheresis is the goal in the 14 days. We need 14 sessions. We need to complete within in the 2 weeks of time or 2 days for 7 to 10 days daily, and until the antibody is negative. And the length of the therapy is 6 months because it is not relapsing. And dialysis patients, they have a poor response. So this is the 2024 guidelines, the flex and cyclophosphamide and steroid, and the recovery may be poor when you have multiplication. So these are the others drug-induced anti-GBM disease. And the pneumotherapy is in Leach he has shown that it's almost a good response. Even those who are requiring dialysis, almost 60% of them they improved, 10 out of 15 improved. So it reduces the antibody, and but again it may, I think, depend on the early creatinine of the renal function, because the degree of fibrosis which determines. These are all the prognostic factors which are suggested. And Dr. Popolani had ANCA vasculitis. Basically, we have to assess an induction therapy either with cyclophosphamide with things, and then combination of rituximab with low dose cyclophosphamide. Intravenous cyclophosphamide is preferred as for avocapan also as a sparing agent, which they have shown that you can reduce the dose of steroids as a good. Flex may be considered when you have a higher creatinine, but again, the recent evidence is equal whether it will help. So this is all the classifications and how we can go about. The summary was the therapy has realized ANCA vasculitis therapy. This rituximab not inferior to cyclophosphamide, and effective relapsing, we can reduce it. And so low dose, we have to use at least 24 to 48 months of therapy to prevent relapses. The key to it was maintain the fertility issues using cyclophosphamide, and refractory disease should be considered the combination of rituximab and cyclophosphamide. Avacopan for withdrawal, cotrimoxazole prophylaxis to reduce PCPs, and we'll have to monitor hypoglycemia when we are treating the rituximab to reduce the infection. And Sachin Alexander said that it is an IGA nephropathy. Now it is a forehead theory. The mucosal pathway is also most important, and the genetic predisposition and the inflammation which happens when the deposition of the immune complex leads to all of complications. These are the supportive care with BP reduction to less than 130/70, RAS blockade, SGLT2. Now these are the ways. Then you can use endothelial antagonists or for example weight loss, smoking cessation, dyslipidemia. Fish oil has a major role. Tonsillectomy is only in Japanese population, and these are all the current things. So multiple drugs which have come to block the therapy. So sabitril-mat on the complement blockers are also on the way for the therapies. So it was improved, evaluate from 2020 to 2018. Now we have a lot of changes in IGA nephropathy, and the newer molecules which are coming hopefully will be able to as of today, it is to reduce the blood pressure, and the Nefigan we are using if it is more than a gram of proteinuria, and the phase 2 trial of BAMF and April blockers are going on. So you can reduce MMF has been used, HCQ, and Ipcobam may come in the future as a complement blocker. So on top of the supportive therapy, we need to decide whether to use Nefigan and then without immunosuppression. And the recommendation by the KDIGO is when you have GFR is more than that, and then it's better to have therapy or go into the trial so that the effective therapy as of today in reducing IgA and the deposition of the complement blockers is not available. And the genetic, the multiple pathways or autosomal dominant recessive, everything is available. Now we can have some genome which gets into the phenotype and the protein. We'll have to have multiple things, NGS. And even exome sequencing will have only 1% of the genome, but it can cover 85% of the diseases. So these are all the different diseases which we can. So again, you have to know in the clinical situation when it will help, and we need to order. And ordering everyone may not work. So summarizing increase, we have to, before embarking on the genetic, we need to educate the patient how it is going to be beneficial. Otherwise, it may have a problem, repercussion after that. So ethical issues are predominant which may come. Implementation of these sciences, it will help, but newer therapies are also coming up as a CRISP and other things which may help in treating bonds. So recurrence in the graph of the colitis explained that IgA recurs almost 60-70, but the affection or the risk of failure is only around 1.6 to 19 on an average around 5. FSGS again recurs in the first, second it will be around 30, and the NPG and C3 is more common. We'll have to have a C3TN and FSGS. We'll have to be very, very careful. 10 to 15% they may have a recurrence. Understanding of the immunology and even the routine and the baseline biopsy if it is there, it will be helpful to manage post-transplant diagnosis. And we have the cases of lupus nephritis difficult to treat, and the nuances of proteinuria because of rosuvastatin and also the cryoglobulin cases. Thank you.